Hey everyone, let's talk about code status. Code status discussion with patients admitted to the hospital is often an afterthought for many providers. You've just completed a lengthy history and physical. You're on your way out the door, and you think to yourself, ugh, code status. So you say, oh, one more thing, Ms. Smith. I have this question I have to ask everyone admitted to the hospital. If your heart stops beating, do you want us to resuscitate you? Well, this is one way to have a code status discussion with a patient. There are many limitations to this approach. Let's discuss an alternative way to have a meaningful conversation about code status with your older adult patients. First, look for a pre-existing advance directive or documentation of prior conversations about advance directives in the chart. It's possible that another clinician has already had a thorough discussion with the patient and has clearly documented the patient's preferences. In that case, the conversation is easy. You just say, I see you spoke with your primary care doctor about a plan for if you got sicker, and I'd like to confirm it with you. If there's no prior documentation, you can still ask the patient, do you have an advance directive or a living will? If so, do you know what it says? It's helpful to normalize the conversation and to ask for permission to discuss it. You want to make sure the patient's understanding of their current health state is accurate. People may make different decisions depending on their understanding of their prognosis. If time is short, a patient may want fewer medical interventions. Next, ask about the patient's values and goals. All of our medical decisions, not just code status, should be in the context of a patient's values and goals. So ask the patient, what matters to you? Next, offer an opinion if appropriate. If a person is clear about her goals of, let's say, going home and focusing on comfort, you can recommend that if her heart stops, we'll allow her to die a natural death because we know CPR won't help her get to her goal. If it's less clear, you can normalize both ends of the spectrum, saying something like, some people tell me they want to live as long as they can, no matter what condition they're in. And other people tell me they care more about being comfortable or being at home, and that when it's their time to go, it's their time to go. Then, ask the patient their preference. Regardless of the decision, ensure your patients that you will continue to do everything possible to care for them within the context of their goals. Patients often want information on how likely they are to survive CPR, so it's important to have some of these stats at your fingertips. For all comers who suffer cardiac arrest in the hospital, 1 in 6 will survive to discharge. For those who arrest from a primary cardiac disease like a ventricular arrhythmia, survival to discharge is actually as high as 1 in 3. But for general medical patients, that estimate is closer to 1 in 10. And in frail older adults, it's even worse, less than 1 in 20. And those who survive often suffer cognitive or physical impairment and disability. It may also be helpful for you to know that certain factors portend a worse prognosis. Cancer, especially metastatic cancer, chronic kidney disease, sepsis, pneumonia, dependence in 2 or more activities of daily living, being homebound, and having dementia. You can use this information to personalize your discussion with your patient to help them decide if CPR is likely to help them reach their goals or not. Everyone has a unique approach to these conversations. Sometimes I find it's helpful to give concrete examples for patients. You might say, let's say you had pneumonia and your breathing got so bad that if we did not put you on a breathing machine, you would die. Would you rather die a natural death or be put in a breathing machine while we try to get you better? In addition, for people who tell you, I never want to be on a breathing machine, not even temporarily, you can tell them that they would not benefit from CPR because it requires mechanical ventilation. Remember, you cannot just be D&I. Then instead of asking them about CPR, you might just tell them that if their heart stops beating, if they were to die, that CPR would not work without the breathing machine and wouldn't help them. You could also take the opportunity of a code status discussion to explore the patient's preferences on other medical interventions, not just CPR and mechanical ventilation, but also things like non-invasive ventilation, ICU level care, feeding tubes, both temporary and long-term, and future hospitalizations. I hope this video has equipped you to have more meaningful code status discussions. Visit vitaltalk.org for examples of these conversations and for more advanced communication skills. Thanks for tuning in. Until next time.